Welcome to Introduction to Traumatic Stress and Trauma-Informed Care. This is our 4th out of 4 modules. We've been moving through the core concepts, and we're now at core concept number 10. And this concept is really based on the idea of culture and the role that culture plays in people's recoveries and experiences of traumatic events. And when we talk about culture, we're talking about those typical definitions of culture that we would think of, such as race, gender, religion, ethnicity, as well as some of those nuances within cultures, which may have more to do with socioeconomic status or beliefs or even the community size of where you grew up. And so culture can affect the way that people make meaning out of traumatic events. And as we talked about in our earlier modules, that traumatic stress is really about what you think those events mean to you. It can also influence how people respond and the level of social support or how their particular backgrounds might view the traumatic event that they've experienced. There's been increasing information and awareness about the role of historical trauma or multi-generational trauma and the role that that may play in people's experiences and their ability to recover. And so if we had more time, we could talk a lot more about that. And it's a significant issue in terms of how people and their families might experience these different events, as well as their interactions with our social service system or our mental health system or our court system, and the way in which they may trust people or not trust people based on the background that their culture or their family might bring. So looking at how culture can both shape rituals that can help families gain support, as well as the rituals that may exacerbate, or the beliefs that may exacerbate some of the ongoing symptoms of traumatic stress. And with core concept number 11, we move to the idea of the social contract. And so challenges to the social contract really affect people's response and recovery. And so we can think of the social contract as the belief that we all have in terms of how the world works and those things that we just commonly accept. So for example, if you pull up to a four-way stop, you have a belief in the social contract that the other cars are going to stop and that you're all going to move forward when your time comes. Stoplight, same thing. When you give someone money for a service, you expect the service to happen. That those, on one hand, are about the social contract, this implicit set of rules about how the world works and the beliefs that we have that govern the way in which those things happen. However, when people experience traumatic events, sometimes there can be a violation of that social contract. So the belief, for example, that parents will protect children is a belief in the social contract that can be torn with the presence of traumatic events. Things that happen at school and people that we think in positions of power. But also that we have a belief in the social contract about what happens to people who commit perhaps crimes against children. And the challenge is that, for example, our legal system has different standards than our child welfare system. And maybe a child welfare situation is closed far in advance of when any criminal action or the criminal process wraps up. And so those can be kind of social contract issues that may cause people to have a very difficult time recovering from traumatic events. So the other aspect of this is when we work within the system, we develop sort of an implicit understanding of how this works. And we know, for example, what happens when someone wants to appeal a maltreatment finding or what a finding means. And it's important for us to recognize that people who are new to the system or who don't work within the system, that there are a lot of issues related to the social contract that may be confusing and may not make a lot of sense. So recognizing how it is that our beliefs in the way the world works impact our experiences in recovery from traumatic events for both children and families is a very important idea. Then when we break this idea of the social contract down to an individual level, we could think of something called the invisible suitcase. And so we all in some ways have an invisible suitcase whenever we walk into a room. So we show up someplace and we have with us the things that people can see. So, our phones, our bags, beverages, things like that. But we also have with us things that people cannot see. And these are our beliefs about ourselves, about our relationships with other people, and about the world around us. And those beliefs are shaped by our experiences in the world. And because we are people, we are designed really to test those beliefs in our invisible suitcase. And so if those beliefs are positive, we will tend to engage in activities that will prove that that belief is accurate. If those beliefs are negative, we will also engage in behaviors that will prove that those beliefs are in fact accurate. So when we think about the way that trauma may shape people's beliefs about themselves or relationships, we can frequently see responses such as, it's all my fault, I'm unlovable, people are going to hurt me, you can't trust anyone. And you could think of a lot of other examples that kids may come up with or people may come up with after having experienced traumatic events. So then what we do as people is we take these beliefs in our invisible suitcase, and kids who have experienced traumatic stress may reenact them. So let me give you an example. There's a 12-year-old boy who his mother died of either an accidental or intentional overdose. And he was with her and watched her become more and more ill. And at one point, he thought about calling the ambulance, and he said he was going to call the ambulance. And she said, don't, because I'll never see you again if you do. And she had a child protection history, so that was possibly the case. So he didn't call the ambulance, and then he ends up waking up in the morning and finding that she has died in the night. So his invisible suitcase belief is, if I make a mistake, people will leave me. So now we have a 12-year-old boy who has that belief, and he's in a very well-meaning pre-adoptive placement, and he'd been through a few other placements that didn't go so well, and then he engages in behaviors that are kind of developmentally appropriate. So he's a young man who takes a shower, and then he puts the towel where 12-year-olds put the towel, which is on the floor. And his foster parents say, will you please go back and pick up the towel? Now, his belief is, if I make a mistake, people will leave me. And so he says, it's not my towel. And they say, you're the only person who's used that bathroom. We know it's your towel. And this goes on and on. And he also has come to this place where he is going to leave them before they leave him. And so this situation escalates in a rather typical way, except then he says, you don't care about me, I don't like it here, I don't want to be here, I want to call my social worker and leave. And they, from a very well-meaning place, one where they care about him and they want him to be happy, say, okay. Except that reconfirmed his belief that if he makes a mistake, people will leave him. And these are how kind of minor situations that relate to those beliefs in the invisible suitcase kind of hook adults into playing roles in these abusive experiences that they didn't mean to play. So I think this is another dynamic that really is very disruptive to placements, to educational settings, because essentially, as I mentioned, the adults become actors in a play, and the kids recreate those old and abusive relationships with new people. And kids can do this for lots of different reasons. It gives them a chance to try to gain control over a topic or over a situation. It may contribute to sabotage, and it may be easier to get out of the situation in the short run than kind of tolerate some distress in the long run. And it really pushes us, or pushes the adults, in ways that they don't expect. And I think sometimes it's really difficult to identify reenactment cycles when you're just looking at the child's behavior. So I think it's also important to pay attention to what our responses are, or what are the responses of the adults that may have got hooked into these reenactment patterns. And typically those are urges or thoughts that are not consistent with how we would typically operate. So if you've ever had the urge to, become really angry, or when you start to personalize a child dynamic with you, you may be caught in the reenactment pattern. And one of the ways that you can think about it is, how can you be the ticket out, right? If children are recreating these old and abusive relationships, you'll leave me, I'm going to leave you before you can leave me. If I make a mistake, people will leave me. Then perhaps it's about saying, you know, we're going to talk about that tomorrow, and if you still want to leave, we can call your social worker then. Or maybe it's about, stay in the room, but we're not going to interact. So really looking at what might be those beliefs that have been created through children's traumatic experiences, and how may those beliefs about themselves or about their relationship with us be contributing to the behavioral issues that we're seeing in the present. So as part of reenactment, or as part of kind of ongoing coping, it does move us a little bit to this idea of the Adverse Childhood Experience Study, which is a study that was initially based on research by Drs. Folletti and Anda. And what they looked at is these 10 adverse childhood experiences. And they realized that these experiences were correlated with adult physical health outcomes. And physical health outcomes like certain types of cancers, high blood pressure, high cholesterol, chronic pain, etc. And what they really discovered, or what they believe, is that when people have those adverse childhood experiences, that they begin to use these kind of adverse coping strategies. And some of these would fall into the idea of reenactment, and some of them would not. But through their use of these coping mechanisms to address those adverse experiences, their risk for ongoing issues increases. And here you can see kind of a pyramid which starts with the adverse childhood experiences, perhaps disrupted development, some functional impairments, topics we've discussed in other modules, and then people as a way of coping adopt high-risk behaviors. And then what we see when we work in child-serving systems is the adults' adoption of high-risk behaviors expose subsequent generations to adverse childhood experiences. This is a fascinating study, and I encourage people to really look at the aces.org website for additional information. In talking about that study, it's important to note that community violence was not an adverse childhood experience that was studied in the original sample. And so we could only surmise or hypothesize that the exposure to community violence would increase people's likelihood or possible likelihood of adopting adverse or maladaptive coping strategies. So core concept number 12 moves us to the effect that working with trauma-exposed children has on us as individuals. And that when we work with children who have traumatic events and deal with very difficult situations, that the providers must deal with the personal and professional challenges as well as the strong emotional responses that may evoke in us. And so we can think of secondary traumatic stress as the reaction that we have as a result of our exposure to traumatized individual stories. And this can be where we as providers start to take on some of those symptoms or dynamics of traumatic stress that we've talked about in the preceding 11 core concepts. And if we don't manage or pay attention to our secondary traumatic stress, it can have an overall negative effect on our work. And that effect can not only impact us, our coworkers, but also the people that we're working with in ways that may not be helpful. So the really importance of recognizing how am I impacted by the work that I do, how can I take care of myself, how can we be more sensitive to the way in which working in really difficult situations affects us emotionally, socially, and how do our systems start to take into account ways that they can help us recover from some of those perhaps symptoms of secondary traumatic stress. So that ends our core concepts, but I want to talk a little bit about screening and assessment and then treatment, given that frequently people who work in child-serving agencies will be people who may be making referrals to treatment or working with children or families who are involved in treatment. And the first important thing to think about is if we don't ask children about their traumatic experiences, they won't tell us. That no one voluntarily discloses the worst things that have happened in their life. And so we need to ask the questions and be prepared to listen for the answers. So if you won't ask, they won't tell. And asking doesn't necessarily hurt people. In fact, it invites a telling and it makes the unspeakable speakable. So this shows us kind of a difference between trauma screening, which can typically be done by anyone who is interacting with a child. It's usually universal. So it's frequently a short set of questions about either have these things ever happened to you, or a short set of questions about traumatic stress screening. Then we can move to a more in-depth assessment, which is a trauma assessment. This would typically be done by a mental health professional, and this starts to look at people's unique trauma symptoms and how those symptoms may relate to other events in their life or other mental health issues. And then the most in-depth evaluation we could look at is a psychological evaluation, which would typically have information about intellectual functioning or personality functioning, as well as trauma assessments and other mental health diagnosis exploration. And we really want to emphasize screening and assessment because we know that sometimes children underreport and they may be avoidant. Sometimes they're afraid of what will happen if they disclose. And we also know that caregivers might not consistently report either based of their own kind of guilt and denial or their own fear about what will happen. And so there's been a well-researched discrepancy on occasion between the reports of parents and the reports of children regarding what children have experienced, what they've seen, and how those experiences are affecting them in the day-to-day functioning. If children have traumatic stress, then there are core components of trauma-focused evidence-based treatments. And here's a brief list of those, but we'll talk specifically about trauma-focused cognitive behavioral therapy, that we can look at psychoeducation and parenting skills, so really normalizing the effects of trauma, talking about our brain's fire alarm, identifying triggers, that we move to relaxation, how do we help children calm down in the moment, stay present in the moment, affect expression and modulation, so that emotional awareness, as well as gaining some insight into how our thoughts and feelings and behaviors are connected. Trauma narrative development and processing really talks about what is the event that happened to you or the events that happened to you, and how do you think about those, and how do we help children correct any distortions and make meaning in a positive sense out of their traumatic exposure so that it doesn't negatively affect their life as they move forward. Trying to gain a mastery over triggers, and really supporting connections between children and their caregivers, because their caregivers will be the people that will provide them the day-to-day support as they move forward in their lives. And then working on enhancing future safety. And this is meant in some ways to reduce the ongoing vulnerability that children who have experienced traumatic events may have as they carry forward, or to address any other issues of safety surrounding their lives. So as we move towards closing, our take-home message really is recognizing that trauma is pervasive, that the impact of traumatic stress and traumatic events on children can be broad and diverse and can shape their lives. It can shape their lives in positive ways, but often with the children that we're working with in ways that may pose increased difficulty for them. And that we want to be helpful, and that providers and practitioners have a role in helping children heal and overcome the effects of trauma. And that through trauma-informed practice, we can all be working together from a common language and a common vantage point to provide cost-effective interventions that in the long run will really pay off in the lives of children as well as in our communities. So some of the material in this presentation came from the work of Dr. Monique Morrow and her collaborators who contributed to Think Trauma, a training for staff in juvenile justice residential settings. I'd also like to cite the NCTSN Core Curriculum on Childhood Trauma Task Force, which developed the 12 core concepts that provided the bulk of the training. So that concludes our 4-module training on the Introduction to Trauma and Trauma-Informed Practice. Thank you for the work that you all do to improve the lives of children affected by trauma in our communities.